Okay, so let's talk about heart and the gut, and I've thrown a few other things in here as well. Basically, who knew the gut would affect the heart, right? Well, we're finding out, again, studies at the Cleveland Clinic and multiple universities, that the microbiome and the heart are so intricately connected. And I'm going to take you through very specifics on speciation today and some of the correlations with heart disease in different species in the microbiome. And this is where you are going to love the new Vibrant testing, the gut pack, because it really includes, a lot of the slides are screenshots from their testing, and I'll show you how that interplays, because you can very specifically know levels of microbes and how it correlates to, say, hyperlipidemia or cardiovascular disease or diabetes. And again, today I'll show you that real specific strain speciation. So this slide just shows basically how the genetics, the medicine, everything goes into play with the gut and how that develops chronic disease, but all of it is based in the gut microbiome. This is a snapshot of a screenshot, I should say, of the gut microbiome and cardiovascular disorders panel that is part of the gut pack of the Vibrant. And as you can see, these different species, which I'm going to talk about today and tell you about, and how they correlate. In this particular piece of the test, you can see atherosclerosis is correlated with the top species, and then changes in lipids in the bottom species. And the one thing I love about Vibrant is what they're bringing out. They're actually testing a lot more species, but what they're bringing out to the clinicians like me is the stuff that actually has evidence base behind it. So any of these species, you can pull multiple studies on the criteria. So Collinsellia is one of the bacteria you saw in that previous panel. And the cell wall has this peptoglycan as a major component. And this excess peptoglycan, so if you have high Collinsellia, can cause an immune response and chronic inflammation, leading to cell formation and atherosclerosis, the foam cells basically. Lactobacillus acidophilus has been shown to lower LDL cholesterol because it converts to this intermediate called corpusculstanol, and when it's converted, you have less cholesterol available for absorption. Now, TMAO, has anyone heard of that, a molecule? Yeah. So TMAO is the hot new topic, and again, this is the big research on this is also out of Cleveland Clinic. And basically, this is a metabolite of carnitine that comes from our food. And it reduces the cholesterol transfer in the liver and increases atherosclerotic risk. And like I said, Cleveland Heart Clinic is actually measuring this as a biomarker in the blood. I was just talking to Mark Hyman recently about, because he's the director of the Cleveland Clinic, and they're doing some correlation with the Functional Medicine Center and this TMAO and actually integrating it into the Functional Medicine Clinic as well as a marker. So basically, there's an intermediate that's converted to TMAO, both in the liver but also the gut microbes. This is where the gut plays into it, convert that. And the substrate is L-carnitine and choline, found in mostly red meat and eggs. Now, there's still a lot of controversy. It doesn't mean you should go throw out your red meat and eggs, but in susceptible individuals, it's like the thing I told you before with genes plus environment. This would be someone who has the wrong bacteria plus the wrong diet will lead to atherosclerosis. So it's a combination of your microbiome. For example, if you had no converting bacteria, you might be able to eat red meat and eggs all day long and never get high cholesterol or atherosclerosis. But the carnitine, in conjunction with the gut microbes that transform it into this TMAO, create atherosclerotic plaques in some individuals. And we know that increased Provotella can increase the inflammation and transfer, and decrease lactobacillus in 2 different species as well. This is kind of the pathway, just simplified for that TMAO as a gut-derived metabolite. You ingest the nutrients from the red meat, the eggs, and then the gut bacteria metabolizes it, and then that is converted by the liver to cholesterol plaques. And then this is just foods that are rich in the TMAO precursors. And the controversy comes for, like, fish has TMAO precursors like carnitine, but fish has been shown to be part of a healthy Mediterranean, healthy for the heart diet. And then carnitine we use as a supplement all the time. And that doesn't contribute to heart disease. So there are controversies. It's not black and white, meaning that you should never eat red meat and eggs. In my mind, it's much more important of what your food ate, right? So if you're eating grass-fed, pastured, organic types of animal products, that's a whole different ballgame in some cases than the conventional raised. And interesting, on the right side there, you can see energy drinks and supplements. These are sources of carnitine. So in the susceptible individual, could it be a problem? And I would say yes, it's possible. Okay, so that's just a little bit about LPS and kind of an intro to the heart. I want to talk about LPS, because LPS is one of the most potent inflammatory molecules in the immune system, and this has a lot to do with our gut as well. So LPS is lipopolysaccharide. It's a large molecule found in the coating of gram-negative bacteria. They're endotoxins, and they've been associated with depression, with schizophrenia, with cardiovascular disease, with diabetes. Almost any inflammatory disease or process that you could name could have an association with LPS. And you can actually detect antibodies to LPS to see if there's been infiltration. Remember I talked about that cell lining and the crossover into the immune system. The same thing can happen with these lipopolysaccharide bacterial coatings when they cross over into the immune system and create inflammatory reactions. This is just a great overview of leaky gut syndrome. I know someone mentioned at the break they'd love to hear more about leaky gut, and in the Q&A I'd love to talk more about protocols and specifics on leaky gut, and you'll see that through this presentation. Leaky gut, or this intestinal permeability, is really a huge underlying factor in many of our patients, not only from poor diet, from processed foods and chemicals, glyphosate Roundup exposure, mold exposure, toxic chemical exposure, but just from bacterial dysbiosis. Many things can cause permeability. And this leads to an immune response, it leads to malabsorption, and it leads to a host of illness. So zonulin, if you follow Dr. Alessio Fasano years ago, discovered this molecule when he was researching cholera, the diarrheal disease that can cause death because of loss of fluids. And what he found in that disease, what the cholera toxin would actually open this zonulin doorway and cause intense permeability so bad that the patients could die of dehydration from diarrhea. And that's when it was discovered, and it kind of gave credence to what us in functional medicine and some of the alternative doctors before us had been calling leaky gut. Years ago, that was laughed at among gastroenterologists, and now you routinely see that in the literature, the hyperpermeability syndrome and the leaky gut as part of the processes for inflammation. So understanding this is really critical to healing your patient's guts. And the zonulin, if you find antibodies to it or you see dysfunction in it, is a clue, because the zonulin is the trapdoor between the cells. So it's the thing that creates permeability when it is elevated. This is a slide that you can see on the left. The colorful blocks are the gluten molecules that, in this case, that's the example, triggers this increase in zonulin, and zonulin basically opens the door between the cells in the middle there. And then you have these partially digested food products going into the immune system, the dendritic cells, which are your sampling cells, and then it creates this inflammatory process. So that leaky gut or permeability, if we go back to the very first slide I showed you in our first hour this morning, that triad, the environment, the genes, and the leaky gut, this is common to all autoimmune diseases. So this is really a critical concept to understand and to be testing and assessing in your patients. You can basically assume, if there is autoimmunity, that that patient has a leaky gut. You don't need to test, because that's part of the triad of autoimmunity. So what are some causes of increased intestinal permeability? Inflammatory bowel disease, you can assume patients with Crohn's or colitis have permeability. I didn't tell you, but just a little bit about my history. 2001, 25 years old, I was diagnosed with aggressive breast cancer. Through functional medicine, I healed myself and I'm surviving and in remission. But a year after that, I mentioned I had had cyclophosphamide and that effect on the gut permeability. A year after I got through chemo, radiation, all the therapy for breast cancer, I developed Crohn's disease. And I'm also in remission from that through functional medicine. But all that to say, in my mind, it's very clear I had a predisposition genetically. I had the DQ2 genotype for celiac. And then I had this toxic chemotherapy in addition to cancer. And that chemotherapy created intense permeability. That crossover then triggered this abnormal response to the LPS and the microbiome, which created Crohn's disease. So I'm a living example of this, how this permeability can affect many diseases, and how addressing it through functional medicine can cure people like me, who I stand here totally asymptomatic from Crohn's and free of cancer. So causes of increased intestinal permeability, inflammatory bowel, as I mentioned, NSAID therapy, small intestinal bacterial overgrowth. We had lots of questions about that. We're seeing a lot of this. Basically, small intestinal bacterial overgrowth, for those of you who don't know or don't test for it, is we should have all of our microbiome reside in the colon. And what happens is this either migrates up through a dysfunctional ileocecal valve or a short gut, someone who's had surgical removal of that ileocecal valve, or if you have poor stomach acid or barrier protection up at the top, it migrates down and you get overgrowth somewhere in the middle in the small bowel. The small bowel was never meant to handle that load of bacteria, and that's why it's a problem. So the small bowel is supposed to be relatively sterile, and you're supposed to have all of your microbes in the colon. But when this either migrates up or comes down through the problem with the hypochlorhydria, you get this overgrowth. And what it does is it affects the microvilli in that region where you're supposed to get absorption of nutrients. And it can't happen because of all those microbes. So that affects the permeability as well because you have damage to the membranes. Celiac disease, protozoal infections, especially Giardia, is an especially wicked one that can cause intestinal permeability. Toxic exposure. My patients I treat with past mold exposure have terrible guts because of this mechanism. Same with glyphosate or Roundup toxicity. Both of those two things, mold and Roundup, are probably the most toxic exposures to the gut microbe and the permeability. Alcoholism. Have you ever treated someone who's been sober for 10 years or 15 years? I have, and what my first thought is their gut needs work because history of chronic alcoholism will always cause dysbiosis, usually SIBO, and sometimes SIFO, which is small intestinal fungal overgrowth. Strenuous exercise. So I'm near Boulder with all these incredible athletes, but did you know that working too hard as far as training, you can actually cause intestinal permeability? So if you're training for the Ironman or some of those where you're doing hours of day of workouts, if you think about the activity and exercise, you're shunting blood to your muscles on the periphery. And by nature, you're going to have less blood flow to the gut. And so I have a lot of people, runners, bikers, intense exercisers that have really, really sick guts. And sometimes you have to ask them to pull back while they heal the gut. There's no way you can train for a marathon and heal a gut. So, and age is a big deal because as we age, we lose our ability to produce hydrochloric acid and pancreatic enzymes. So basically anyone you could test for permeability, but in specifically food allergies, gluten sensitivity, autoimmune disease, neurological conditions, cognitive dysfunction, and metabolic and cardiovascular disease, as I'll explain today. These are some of the markers you can check for endotoxins, actomycin, occludin, and zonulin. And as part of the gut pack with Vibrant, they test for leaky gut for certain species. They also have part of the wheat zoomer, I believe, has a leaky gut panel as well. So I mentioned Giardia. This is actually surprisingly common. I went on a medical mission trip in 2006 to Honduras, and I brought Giardia back with me. So it's not fun, I can tell you, and it requires usually antibiotics. With parasites, I believe most of the time they need medications. I don't usually mess around with herbs because I find that some of these are so hard to eradicate that you can play around with herbs a long time and never get rid of them. So that's just my personal clinical opinion. Lactobacillus plantarum is a very common and versatile lactic acid producing species, and studies show when given as a probiotic, it helps fortify that zonulin. So this is pretty profound because you can actually use this species to help with that leaky gut. Short-chain fatty acids, we've all heard about those, and I've got some studies to show you on those specifically. These are produced by bacterial fermentation in the gut. So if you don't have the right species that create short-chain fatty acids, you're going to be at a disadvantage because those are very important to a healthy gut lining and a healthy microbiome. Butyrate is the one that's probably the most important. It sounds like butter, and it comes from butter. So your patients who have very, very low butyrate can increase that by consumption of ghee or butter. And many bacteria on that previous slide, this one, are butyrate producing. This butyrate will regulate mucosal inflammation and oxidative stress. It reinforces those tight junctions and heals the zonulin. It modulates permeability and peristalsis. And there's an association with decreased colorectal cancer as well. So this is a study specifically for short-chain fatty acids, primarily acetate, propitiate, and butyrate, that are metabolites formed by the gut. And two in particular, butyrate and acetate, were reported to protect against diet-induced obesity. This study showed the role of SCFAs has expanded to include their role as nutrients. So these are the fuels for the colonic enterocytes, and also other functions like ion transport and regulators of proliferation and gene expression. So it's no wonder that we see it as an anti-colon cancer thing, because it's actually regulating gene expression. And again, with body weight, short-chain fatty acids may enter the systemic circulation and directly affect metabolism or function of peripheral tissues. They can modulate adipose, skeletal muscles, and have all of these effects. And they may contribute to improved glucose homeostasis and insulin sensitivity. Love this slide. I've been using it for probably 7 or 8 years. The original author was Dr. Patrick Canaway, a good friend. But this basically shows you how all of these things, diet, emotions, infections, toxins, systemic disease, all play into adding up to intestinal permeability alterations, and then they manifest in our patients as food allergy, malnutrition, dysbiosis, toxic overload. In my book, I'm not usually directly checking zonulin or anti-zonulin levels, but what I am doing is, if the patients are incredibly chemically sensitive, or if they have multiple IgG food allergies, I assume that there's permeability, and I treat it as such. But basically, if you think about this alteration in the cells, the tiles that have lost their grout, you have all that transfer of stuff that should never be in the bloodstream, and it's a huge toxic burden to the liver and to the body. So if you think about total toxic load in our little bucket that flipped around and around, part of this is internal. And you can decrease your patient's total toxic load by working on the gut. I will tell you, after, again, back to mold exposure, glyphosate exposure, toxic exposures, after getting them out of the exposure, so say they're in a moldy home, moving them out of the house, or after getting them to consume an organic diet so they're not consuming glyphosate, then very next thing that I think is most important is healing this intestinal permeability that was caused by the toxin. And the other thing is, I think someone over the break was asking me a question about detox and mercury and some of those things. I feel like the core is getting this gut to work, because our liver is designed to phase 1, phase 2, take toxic chemicals and biotransform them into soluble intermediates that can be excreted in the bile. And the bile is our way of getting rid of toxins through the GI tract, through the gut, through the stool. But in patients who are really, really toxic, what they'll do is they'll have this merry-go-round in the gut with the bile acids where they keep reabsorbing toxins. And that toxic burden never decreases. So part of this is whether you use binders like clay or charcoal or cholestyramine or the fiber that Todd mentioned. I can't wait to try that, because that's exactly this mechanism, as I'm assuming it's a charged particle that's grabbing onto some of these toxins and pulling them out. So all of these ways that we can use are really key to lowering that systemic antigenic burden. Okay, so diabetes, and this is in the heart talk because, as we know, diabetics are at a dramatic increased risk of heart disease and heart attack. And endotoxemia is just another name for that LPS that I explained to you and crossing over into the immune system. So endotoxemia is basically when there is this LPS as a trigger for insulin resistance, obesity, and diabetes. And it increases during the fed state and decreases during the fasting state. So you know all those studies that are coming out about intermittent fasting, fasting in general, all of these different things that people are using, especially with longevity and mitochondria health. We've shown that intermittent fasting and fasting in general and decreased caloric intake has been shown to decrease or increase longevity. Well, that happens on a mitochondrial level, and that's because you're having less endotoxemia. So the LPS concentration 2 to 3 times normal is what defines metabolic endotoxemia. And we know that a high-fat diet can actually increase the proportion of LPS crossing over. Now, don't get me wrong, I think a ketogenic, very high-fat diet for some populations is phenomenal, even in some autoimmune disease, some seizure disorders, neurological disease, sometimes even cancer. I use that as one type of dietary intervention, even though it's a high fat and you would assume that it may, but you do have to keep in mind if they have severe dysbiosis, you might be increasing the crossover, the endotoxemia on the high fats. So it is a thought consideration. In this study, metabolic endotoxemia was induced for 4 weeks in mice by this continuous infusion. So they were artificially given an infusion of LPS. This is what happened. Increased weight, increased markers of inflammation, that would be like CRP, increased triglyceride production by the liver, and increased insulin resistance. So this metabolic endotoxemia through LPS crossing over dysregulates the inflammatory tone, triggers weight gain, and triggers diabetes. And if we can lower the plasma LPS, we can control metabolic diseases, and we can do that through the gut. Okay, so I wanted to be more than just pontificating on all of these studies and give you some practical. So I looked in the research and said, what can we use naturally to prevent this LPS endotoxemia? And these are the top 7 that I came up with, and I'll show you all the research on them. Physical exercise, quercetin, curcumin, sulforaphane, resveratrol, EPA, DHA, and bifidobacter. So this study was physical exercise induces an important suppression of the TLR1, that's toll-like receptor 1. Those are part of the immune system. And this signaling pathway basically happens in the liver, the adipose tissue, the muscle, and the physical exercise reduced that endotoxemia. This study was on another favorite of mine, quercetin, which is a natural occurring flavonoid, shown to downregulate inflammatory response and provide cardioprotection by inhibiting LPS-induced phosphorylation. So this is profound. I love quercetin for multiple reasons. It's a potent antihistamine, can be used, I think I mentioned that earlier, and it's a wonderful flavonoid. The one caveat with quercetin is if you have a COMT double homozygous, they have more trouble breaking down catecholamines and estrogens, and quercetin is an inhibitor of COMT. So curcumin also attenuated LPS-induced cardiac hypertrophy. Love curcumin. I think Todd talked about that well. They have a great product, so ask him about that afterwards. But curcumin is possibly, or no, it was a pharmacist who talked about vaginal curcumin. Phenomenal. Love that. I would like to start trying that in my patients with HPV. I have one in particular in mind. But curcumin is potent anti-cancer, anti-inflammatory. I use it anti-pain. It has multiple effects, and in this case, it affected LPS and cardiovascular disease. Sulforaphane. So this is broccoli extract, a neutral biological active compound extracted from cruciferous vegetables, and it has a potent anti-inflammatory, anti-cancer, and significantly suppressed the LPS-induced COX protein. Here we are again, sulforaphane. This is pre-treatment, and this prevented that LPS-induced injury. Resveratrol, which is from red wine. Love resveratrol, another favorite, and all of these also happen to be mitochondrial support. So curcumin, quercetin, sulforaphane. These are, if you want the bang up high potency mitochondrial support, you can list all of these as well for that indication. This is EPA DHA, basic old fish oil, and this showed that both EPA and DHA downregulated LPS-induced activation of NF-kappa beta. And then lastly, bifidobacter. Strains of bifidobacter are effective in inhibiting LPS-induced inflammation and could be an intervention in chronic intestinal inflammation. So this is where practical application, I would make sure that your probiotic strains contain bifido species. This is especially true in infants. It's especially true in those with SIBO because lactic acid producing bacteria can often be more problematic than the bifidobacter. And it's especially true, as we can see, with LPS-induced endotoxemia, so diabetic, obesity, insulin resistance. And the very bottom there, these improve tight junctions. So we talk about leaky gut treatments. Bifidobacter has the ability to positively affect the gut barrier. This is another study on bifidobacteria reducing endotoxemia. Obese and diabetic mice display enhanced intestinal permeability and metabolic endotoxemia. Increase in bifidobacter reduces the impact of that high-fat diet translocation. So here's a perfect, I'm just, again, postulating, but What about if we have someone who needs a ketogenic diet, that high-fat diet that could actually induce the LPS transfer, and we put them on high-dose bifidobacter? Could that potentially work at blocking that? I think so. Dietary intervention. So as I mentioned the first talk, diet is so huge and should be our first line of intervention. So increasing low mercury fish is very powerful. Increasing whole plant food. My practical way to get patients to do that, and what I do myself, is I encourage smoothies, because you can load a Vitamix full of spinach and leafy greens, and they don't even taste it. It's part of that morning smoothie. I'm a huge fan of that. And as I mentioned earlier, I love parsley and cilantro for detox. So personally, I'm going to throw a handful of parsley in that smoothie as well. You can use chlorophyll-based greens as well. Avoiding sugar and processed foods is really key. And increasing dietary fiber. So like I mentioned, I'm very anxious to try the new Zymogen fiber. I'm a huge fan of real food as the form of chia seed, flaxseed, or psyllium. You can add those to foods. I even have people, if they're baking fish or roasting vegetables, sprinkle some chia seed on, garlic and sea salt and some olive oil, and it gives it a little crunch, especially for the grain-free people who don't have the grains to do that. I love chia seed, and I have people do that all the time. It's also loaded with omega-3, 6, and 9 fatty acids. Oh, I mentioned the bottom there, intermittent fasting. That can be powerful because of the anti-aging effect and the decrease in the LPS transfer over the gut. And here's the soluble, insoluble fibers. They feed the SCFAs that we talked about, so the short-chain fatty acids. And you just want to make sure your patients are getting lots of fiber. I think this is especially true for those who are new to something like the paleo or autoimmune paleo diet or the low FODMAP diet. A lot of mistakes can be made by not making sure your patients have adequate fiber. Most of you are very knowledgeable, so I probably am preaching to the choir, but if someone were to ask me how do I eat and how do I stay cured from Crohn's and cancer and all that, I'm pretty close to an autoimmune paleo. I'm grain-free, I'm completely processed food-free, egg-free, dairy-free, soy-free, corn-free. It's almost easier to say what I do eat than what I don't. But the important thing about that is I eat a lot of vegetables, a lot of fruit, a lot of nuts and seeds, actually no nuts, lots of seeds. And so when people hear that paleo, especially your patients who maybe think it's like a bunch of meat, I eat meat 4 times a week. I don't even eat it every day. So what's important, and I still consider myself paleo, I think that's really important to get across to your patients that it doesn't mean you're going to, and I have no problem with consuming grass-fed organic meats, but I think the importance is these leafy greens, these seeds, these soluble fibers, these fruits, and then having that protein. In my mind, it's higher fat, moderate protein, low carb is kind of the ideal plan for some of these types of things. Okay, prebiotic and probiotic are essential. So the prebiotics would be all the things we just talked about, the fibers that feed the probiotics. Now, one caveat. So if you have someone with SIBO, or if you have someone with SIFO, and you give them a probiotic with prebiotics like FOS or inulin, they will very likely not tolerate it because you're feeding the bad guys. So you have to clear out the SIBO or the SIFO or the dysbiosis before you give prebiotics, or you'll have a miserable patient. Now, I mentioned the one case with treating Xifaxan in the study with gargum. That's a prebiotic. So you're going to have miserable patients, but you may have more effective treatment. And you have to keep these things in mind when patients come to you and say, I can't tolerate probiotics. You know what I would look for? SIBO. Because usually those patients have some problem with overgrowth already in the small bowel of lactic acid producing organisms. This local company study on a Lactobacillus plantarum 299V, and this is out of Boulder. It resulted in decreased circulating leptin levels, smaller myocardial infarcts, and greater recovery post-ischemia. So pretty impressive. Okay, so let's dive into some specific microbial species that you would see if you ordered the gut pack. Low bacteria richness, we talked about this ad nauseum in the beginning, but we know that low and high bacterial richness is a correlating factor with disease and health. So low bacterial richness is consistent with reduction of that butyrate-producing bacteria, an increase in mucus degradation. So if you think about mucus lining the gut and protecting you from ulceration and Crohn's and colitis, the species that produce mucin are very important to health. And some of those we'll talk about, specifically A. municipilia and R. navis. And low bacterial richness is also correlated with increase in oxidative stress. This study showed that decrease in butyrate-producing Rosburgia hominis and fecal bacterium Prosnitsky defined dysbiotic in patients with ulcerative colitis. So remember, I just got done telling you many of these species are mucin-producing. So they produce the mucus lining that protects you. And of course, it makes perfect sense to me that you would have lower of those species in patients with ulcerative colitis. And that would also increase inflammation with the absence. This is one of them, fecal bacterium Prosnitsky. And it is significantly lower in obese and in diabetic patients compared to lean individuals. This is another one, Akkermansia, and this is a mucin-degrading gram-negative bacteria, about 3 to 5% of the microbiota. Concentrations are inversely correlated with obesity and diabetes, so lower levels of Akkermansia, higher levels of diabetes. There's one particular stool test where if you see this very, very low, it correlates with low diversity, just this one species absent. So you would think that diversity is always associated with just counting up a number of species, right? It's not that way, because according to some of the research, there's certain species that matter more. This is one of them. So if your patient has no Akkermansia, they automatically qualify for low diversity. That's kind of an interesting pearl. And then prebiotic consumption will increase these guys. So back to the pre and probiotics and the fibers that we're using, you can actually feed the right bacteria and increase the levels. Administration in the rat models improved weight loss, metabolic control, and adipose tissue inflammation. And metformin. Remember I said I think sometimes drugs are maybe working through the microbiome? In this case, metformin increases concentration, and increased concentrations are related to less insulin resistance, less diabetes. What if part of metformin's activation was just through the microbiome? Inflammation. So butyrate-producing bacteria like Rosburgia and fecal bacterium are lower in type 1 or 2 diabetics, and these basically, as we can increase that Akkermansia, we're going to see anti-diabetic effects. Atherosclerosis. So there's some very specific species that are correlated, and this is back to the oral cavity. So I'm not going to try to pronounce those, you can see them. Streptococcus, I guess I can say that one. They've been found in plaques, but they can also be present in the gut. And patients with atherosclerotic events had higher levels of that Collinsellia, that was the one I mentioned in the first slide, and lower levels of these mucin-producing bacteria. This is part of the gut pack, and you can see these specific species I've been talking about on the atherosclerotic risk. This is that Collinsellia, was enriched in patients with systemic atherosclerosis, defined as stenotic atherosclerotic plaques in the carotid artery, leading to cerebrovascular events. Whereas these other two good guys, Rosburgia and Eubacterium, were enriched in healthy controls. Now the difficulty is, at least at this point, we don't yet have strain-specific species of all of these things where we can give them to the patients. So I can't go out and buy a Rosburgia probiotic, right? I think the key is, though, to understand how food and prebiotics and fermented foods and probiotics can modulate the gut. And that's where we get a clinical application. Here is, again, a screenshot from the gut pack and all of these high LDL cholesterol-related microbes. These are all important to have in present versus absent. More on diabetes. So there's a signature that increased Firmicutes related to Bacteroidetes is associated with type 2 diabetes and obesity. And that's because we talked about one slide a few times ago where there's increase in production through the liver of triglycerides. I think that was associated with LPS as well. And then sulfate-reducing species, Desolvibrio, was frequently observed in diabetic patients and decreased for the butyrate synthesis, again, the same ones I talked about before, Rosburgia and fecal bacterium Prosnitsky were both prototypical butyrate producers, and they're decreased in diabetic patients. This is just a great slide that shows how the microbiome affects fatty liver, affects type 2 diabetes, affects obesity, atherosclerosis. So all of our body, especially heart and metabolic syndrome, can be affected by these bugs. So summary, lower butyrate producing bacteria, Rosburgia, fecal bacteria, are going to be found in your diabetics. Higher Lactobacillus gasseri, Streptococcus, certain Clostridia, and Proteobacter. And then increased expression of microbiotic genes often involved in oxidative stress, which lead to pro-inflammatory signaling, and lower genes involved in vitamin synthesis like riboflavin. So that's kind of a summary of what you would find in a diabetic patient. Blood pressure, who knew that was related to the gut, right? For me, this was like, wow, it affects everything. Emerging evidence suggests that gut microbiota is critical in maintenance of physiological homeostasis. There was decreased microbial richness, diversity in the spontaneously hypertensive rats. So remember diversity? In this case, decreased diversity, increase in hypertension. And increase in Firmicutes bacteroidetes ratio, which is also associated with diabetes and obesity. And these decrease in butyrate producing bacteria led to high blood pressure. Same thing, more Firmicutes, less bacteroidetes, that combination increased the metabolism of catecholamines and actually altered the gastrointestinal and renal or kidney ion transport, leading to salt sensitivity. I just pause because does this not blow your mind of how the microbes affect renal transport of sodium? It affects everything. It's so profound. And again, I'm just touching the surface of what we've just got out. These are all pretty recent studies in the last either 2015, some of them are even 2016. We are going, if you keep abreast of the data, we're going to find out more and more and more about how the microbiome affects every aspect of health and disease and how altering the microbiome can heal your patients. So diet influences, this is just some interesting, so animal protein saturated fats favor a Bacteroidetes enterotype. Vegetarians favor Provotella enterotype. And then fiber is associated with Bacteroidetes and Actinobacter. Negative association with fiber is that one I keep mentioning with diabetes and heart disease, and that's Firmicutes species. And I mentioned metformin and how drugs can actually alter, in this case, the disruption of the bacterial folate cycle, resulting in decreased synthesis of SAMe. And so maybe part of the effects of a lot of our drugs are acting on the microbiome. So in summary, this is kind of hard to see. I like the little smiley faces because bottom line is on the left side you have this balanced gut microbiome where the happy guys are more than the unhappy, sad, harmful organisms. And that's going to lead to decreased gut permeability, decreased toxemia or endotoxemia, decreased pro-inflammatory molecules, increased insulin sensitivity, and overall better gut and heart disease health. And when you have the opposite, which the arrow going over is high-fat, high-sugar diet. Okay, so let's talk a little bit about testing. And these are all, again, panels from the gut pack. Basically, this is a panel on gut bacteria and intestinal disease like IBS and IBD. So pearls, Akkermansia, you've heard me talk about that. This is a mucin-degrading bacteria, principal component of those mucous membranes. Akkermansia is one of those that's highly correlated with diversity. If you have absence of Akkermansia, you have absence of high diversity. And it also helps that mucus lining, so low levels of Akkermansia is associated with ulcerative colitis, which makes sense in my mind. Bifidobacter produces vitamins, absorbs antimicrobial chemicals, and also produces short-chain fatty acids. And E. coli, there's good and bad strains, but we do need E. coli. And the harmless strains will help produce vitamin K. Autoimmune disease. This could have been in my first presentation, but I wanted to put these all together here. This is another piece of the panel where you can see correlations to celiac disease, RA, psoriasis, Crohn's disease. In celiac disease, we see higher levels of Klebsiella, which can trigger autoimmune disease. That was one of those microbes I mentioned with autoimmunity triggers. Lactobacillus may alter the digestion of gluten polypeptides and exert protective properties. So that's a good one. And Provotella has been associated with RA and with celiac. And then other considerations, the Stenotrophomonas and RA, Odorobacter in Crohn's disease, and Propionibacter in psoriasis. Metabolic disease, again, we talked about some of these: obesity, type 2 diabetes. Lactobacillus rhamnosus, this is a good guy. This has insulin sensitizing effects and is anti-inflammatory, and you can get that in a probiotic. Most of the ones I like to use contain Lactobacillus rhamnosus. This is a side note, but so I don't forget, I think it's kind of important and practical. Did you know that certain probiotics can make higher histamine levels and certain probiotics can lower histamine levels? Do any of you have patients who have problems with histamines in foods or histamines in general? So Lactobacillus acidophilus Lactobacillus casei can actually increase histamine. So if you have a patient with histamine issues, you do not want to give them a probiotic with Lactobacillus casei. Lactobacillus rhamnosus, which is this first one, is neutral. So it's fine really either way. Bifidobacter may lower histamine levels. So if I have someone with histamine intolerance, I choose the probiotics accordingly. And then butyrate-producing bacteria, we talked ad nauseum about that, how important it is, those short-chain fatty acids. And this may be why butter is such the hot topic now, at least organic grass-fed butter and the bulletproof coffee, because butter does have a really good effect on the gut, short-chain fatty acid production. Oxalobacter forminges is correlated to kidney stones. So if you see that on this panel, you may have someone who is, see that last little line there, it says kidney stones. You may have someone who's at risk for kidney stones. So who should you do that in? I would say everyone. Everyone who comes to my clinic gets a stool test. But if you're wondering specifically, IBS, IBD, of course, standard American diet, neurological mood disorders, autoimmune disease, metabolic disease, cardiovascular disease, post-antibiotic treatment, pregnancy, and anyone considering FMT. So fecal microbiota transplant is the hot new topic, and there's really good evidence with C. diff colitis. And so if you're going to have, someone who's a candidate, you'd want to do this kind of comprehensive testing before you'd initiate. This is another screenshot of the commensals of how you can test. So bottom line on all of this is use these types of tests. They're at our that we have amazing tools that we never had years ago, and you can now be very specific about your patient's microbiome. And so I would tell you, start with yourself. Get, Susie mentioned the good, price on the test kit. I would try it on yourself. That's what I did. I tested myself and my husband, and I said, wow, this is so cool. So start there and learn because we learned through ourselves, and then we can make changes accordingly. Okay, but what do we do, right? Practical. So my last few slides are just very, very practical, and I'll try to infuse a few tips. There's just literally 7 or 8 slides here about manipulating the microbiome. So the basic 5R program. Now the core here, someone asked again about break. What do you do about leaky gut? Well, here's the most important thing. You cannot heal a leaky gut if there's a toxin, if there's a pathogen, if there's something else. So don't just go throwing glutamine at your patients until you find out what's going on. So you need to know the cause, whether it's toxic chemicals, toxic mold, infection, parasitic issues, SIBO. You need to do the testing to find out what is causing the permeability issues. You need to then treat the dysbiosis first. So that's the remove here. First thing in the 5R program is any abnormal microbes, so bacteria, yeast, parasites, toxic chemicals, stress, food sensitivities. You're never going to be able to heal the gut if you just throw glutamine or something that you've heard heals a leaky gut until you fix the dysbiosis, and that's the first step. These are going automatically, so I apologize. We'll go back. So food sensitivities, check for those. Elimination diet is a core, and if they can't afford testing, you can always do the top 7. Do you know what those are? Gluten, dairy, egg, soy, corn, alcohol, sugar. So if you don't want to test or they can't afford it, just take them off those 7 foods, and I guarantee they'll feel better. And they can always reintroduce the ones that maybe they don't have a sensitivity to. I often use drugs or herbs to eradicate a particular pathogen. I have a whole slew in my armamentarium. And then avoid genetically modified foods and xenobiotics. This is huge. As I mentioned over and over again, how toxic chemicals affect the gut. Replace, this is the next R. So if they need digestive enzymes, you can replace those with plant-based enzymes. Usually what I do is if patients have significant pancreatic insufficiency, I will use a pancreatin-based enzyme. If they have no sensitivity to mold or aspergillus, I will use a plant-based enzyme. But most plant-based enzymes are made on aspergillus, So do not use those in your mold-sensitive patients. Prescription enzymes are also a possibility. Hydrochloric acid, bile acids, and botanicals. So you can use bromelain, papain, ginger, gentian, violet, and Swedish bitters. Probiotics are the re-inoculation. Now this is kind of a misnomer because it used to be like we're planting seeds in the garden and they grow, and they don't really do that. It's more like we change the immune function by the interaction between the probiotics and the immune system. Prebiotics, we mentioned inulin, fructooligosaccharides, arabinogalactans, fiber, chia seed, ground flaxseed, psyllium, and many more. And then Saccharomyces boulardii is a really good probiotic, especially in the case of antibiotic use because it's resistant, it's a yeast form. Repair, you can use vitamins and minerals. I'm always checking for zinc and magnesium and B12 and vitamin D and vitamin A and using all of those things if they're low. Immune support, you can use whey protein or colostrum, or you can use precursors of glutathione or glutathione itself. Antioxidants, anti-inflammatories, I mentioned curcumin and fish oil. And then mucosal healing agents, glutamine and aloe are helpful, deglycerized licorice. And my new favorite is a soil extract, lignin extract. And if you want to ask me about brand names, I can tell you over the Q&A. Rebalance, lifestyle change. So you want to make sure they're sleeping and clean air and clean water and all those things we talked about. Sorry, these are automatically going. And then the balanced heart and brain, I mentioned heart math, acupuncture, yoga, tai chi, because gut and brain are so intricately connected. If they are a ball of stress, you're not going to be able to heal their gut. And if it's something simple, you might get them on the heart math program for their iPhone because they can do it on their phone. It's very simple. The basics, I often use a hypoallergic protein powder, pea or rice-based or similar. Glutamine can be helpful. Vitamin D and vitamin A synergistically will help heal a leaky gut. Probiotics, essential fatty acids, B vitamins, and sometimes a multivitamin with minerals. Okay, and I'll end with, this is important for us and for your patients, mindfulness is being aware of what is happening right now without wishing it were different, enjoying the pleasant without holding on to when it changes, and being with the unpleasant without fearing it will always be that way. I thought that was so good, so that we can just be in the moment and like today, just learning and then not worrying about the rest of your day until you're gone. Okay, so that's it for the cardiovascular disease, but I definitely have time for Q&A. So we'll go back to that with the microphone. Thank you.
Hey there, I do work with inner city kids, volunteer, and from age 12 to 16, they're really unhealthy. So they're low income, they are pre-diabetic, they're anywhere from 25 to 75 pounds overweight. And one of the boys I was with had hives. We went around the block, he had hives, his skin was itching, he had scratch marks. And he was coughing from his asthma. So what I ask is for the future, in the next 10 years, being that the Hispanic population will really be the largest population in our country, and there's a lot of low income, as a doctor, they don't have access to all this. So what do you think is going to happen for the future of that?
So this is a great question because I am not a political activist. I hate politics, to be honest. I'd rather be in my room reading about microbiome. But what I do know is that we have to be active. We have to change at the level of, number one, what we purchase, because the dollar speaks. For example, my brother, who's now doing organic farming, he's a businessman too, and what he saw was people are starting to pay more for organic, so there's a premium on his crops. And as a businessman, besides just the idea that it's a better thing to do for the environment for his children, what he decided to do was to do what the people were paying for. So as we choose to pay more for organic and to make that choice and to not, buy the processed foods from the big companies, that's a piece of it. And then as we choose to be involved and demand that we regulate genetically modified food, and more than that, more than labeling, it should be outlawed. I mean, to me, labeling is just a tiny little bit of the issue. Why is Europe seeing this and changing their food? And why do my patients go to Europe and they eat all the food that they can't eat here and they're fine? To me, there's a big problem with our food industry, our food supply, our agricultural. And I hate for it to be that big of an issue, but it is, and I think that's where it starts. Because unless these, our subsidized, our school meal programs are genetically modified corn and soy and wheat and garbage. So until we change the industry, it's not going to trickle down to those who can't afford to choose. And I think that's where it has to start. So.
Yes, I'm kind of curious how you do a blood pressure on a rat, but my question is, my imagination is, my question is I've been recommending 12-hour fasts only because it seems that that's doable and kind of practical for most people, but with some of those patients that you mentioned with bad RA, what kind of fasts are you putting them on? Are you putting them on elemental diets? If so, what? And for how long and how often are you doing this kind of fasting for people with severe autoimmune issues?
So I think that this fasting and intermittent fasting is this untapped potential to heal, and I'm a big fan. The contraindications would be those with really bad adrenal dysfunction. They can't stabilize the blood sugar for that long, and so that might be someone who wouldn't do well on an intermittent fast. Of course, pregnant women should not be intermittently fasting. And women in general will not do as well, just metabolically, how we're created, the hormones. Women have a little bit harder time than men on intermittent fasting programs. I've seen 12 and 16 hours, and all you do is basically say your last meal is 6 p.m., you can go till 6 a.m. the next day or extend it till 10 a.m. So you just make your period of not eating longer. One way that a lot of the patients are doing something like bulletproof coffee in the morning, where they have either MCT oil in their coffee, and that actually induces ketogenesis very quickly. So you can actually fast with coffee, and brain turns on. I drink that every morning when I wake up. I don't put butter in it, but I do put brain octane in it, which is a high N10 MCT oil. Love it, and then I'll have my breakfast a few hours later. So, but again, adrenal issues, pregnant women in general may not tolerate it as well, but I think it could be very helpful. And the longevity studies on mitochondria are profound, and the most profound intervention is fasting, more than any other nutrient. So maybe we should start to use that. I think there is a place for it. Yeah.
I have a question. So I'm trying to wrap my head around the practicality of doing additional testing. If I do a lot of treatment with people who have prediabetes and diabetes and are substantially overweight, and one of the things that I've become interested in is how, after being extremely successful in getting these people to reverse all of their parameters and lose their weight, do they struggle so hard at maintaining everything that they've accomplished? So I've hypothesized, and I don't know if you've noticed this, that perhaps we're not ultimately creating a change in the microbiome yet for these individuals. And so the microbiome sort of creates an imbalance and a tendency to create a desire for these patients to continue to crave, to eat in a way that is feeding an imbalanced microbiome. Would it make sense to maybe get a look at the microbiome before you start them on all of your treatment, and then before you say, yes, I think you're better, check their microbiome again and see if they've actually restored that balance?
I love that, because I would say my people who come in and they just haven't had success with weight loss, or like you said, they've lost and then they gain, or they can't maintain, almost always I find a microbiome issue. Number one would be SIBO. I've seen people lose 10 pounds in 10 days on a SIBO treatment, boom, just because they switched that microbiome. Basically, it's toxic overload, which overloads the liver, which overloads, all the things that would cause weight loss. So I think that's huge, and I love your idea to start with that and kind of assess where are you at, where do we want to go. And again, just remember, you don't need to remember a huge amount of supplements. You need to start with diet and food, because food can change the microbiome. So you start there. And then all the rest is bonus, which I use lots of supplements. I believe in them, but I always start with food.
Hi, Dr. Jill. My question is, first of all, appreciating and accepting what you're saying about going back and starting with this particular patient at the microbiome level, looking at the diet, food, all of the things that you're saying, we will do that. But the really odd thing is just the spastic. This person has the double gene of the MTHFR, So then they've got spastic high blood pressure, which will go from 198 or 207 in 1 minute later down to 136, up to 157, up to 190. You know, it'll just, you can do that with running 6 in a row. And then the person will do, you know, running 3 miles a day, exercising, all of that stuff. But yet this has been a bear to get it to stabilize. Although it's come down, it's not going over 200 anymore. They're petrified of medications, so you know, you're just kind of praying for an answer before something else happens. But you know, the stroking is a potential for the MTHFR, what it can contribute to. So just wondering, first of all, going back to all of your protocols that you're saying, is there anything else that you think of when you hear about that?
Yes, because just from clinical experience, I have these puzzling, you know, young men that 32 and they're on high blood pressure meds, like four meds, and still aren't controlled. So I've had a few things that I've come across, and this is just my clinical experience, so take it for what it's worth. One patient, severe lead levels, lead toxicity. We treated the lead, his blood pressure went down, never needed medication. I had a couple of patients that were like latent celiac, so a pre-celiac, a latent celiac, where gluten was the trigger. They got off gluten and their blood pressure went normal. Same thing with other foods. I've had a few foods be a trigger. And again, that would be because of permeability, but food I would check, so I would check for heavy metals, I would check for foods. I've had a few patients who have had a toxic exposure that raised TGF-beta, which will raise blood pressure. And you get them out of the exposure, you treat the toxicity, and the blood pressure goes to normal there. Let's see, what else has been unique? Because some of those are really, and they're the ones that come see us because they've been to the cardiologist and they're the abnormals. They're not the typical overweight, you know, hypertensive. They're the unique case. But immune, so anything that, just like we talked about the whole first hour and a half lecture on immune activation, anything that causes a strange immune activation could also cause this spiking blood pressure. So I would look at the immune system, toxic chemicals, gut, heavy metals, all of those things as well. And it can be, I would say some of those patients have been my toughest because I know if I find it, the trigger, I can fix it, but it can be really hard to find. You know, you mentioned MTHFR though, and I would suspect there's been another case where they needed like the Deplin types of doses, the 15 milligrams of methylfolate to get resolution of symptoms. So it might be just they're not adequately dosed on methylfolate. That could be a huge issue for them. Okay, so you might want to keep going and make sure they have riboflavin, methyl B12, all the other cofactors in there as well. You're welcome. Those are tough cases. Oh, we have someone up front here too, Eddie, if you want.
Yeah, I have a quick question. It's just, what company do you use to test TMAO right now?
Oh, good question, because Joel Kahn and
Cleveland Heart Lab actually
thank you.
tests it.
Thank you. Because I was thinking, I know that the guys, the cardio guys that I was with on the weekend, they were yeah, Cleveland, I'm sure, is the one.
Dr. Carnahan, sometimes you mentioned that you have to resort to antibiotics. So I'm wondering what you do in those cases to quickly build up the microbiome back up to avoid and mitigate dysbiosis.
So I have a perfect example. Someone very near and dear to me. My dear husband flies all over and works out of town in Nashville, and he flew home about mid-February. He brought with him influenza A, very, very bad, one of the worst cases I've ever seen. He was down for a week and got well from that, developed shingles, and then C. diff colitis. This is my husband. How embarrassing is it that I'm telling you that? So bottom line, he had to go on vancomycin, which is it's a bomb for the gut, right? So here's my plan. Number 1, Saccharomyces boulardii during the antibiotic high dose. Number 2, as soon as he's off, I'm going to flood him with about 950 billion probiotic. And there's studies on that Lactobacillus planetarium that I showed you. And you can get that strain specific in a probiotic, or you can get it in that product from Boulder. That has been shown to decrease or to increase tight junction. And of course with C. diff, it's like cholera. You've got destruction of the tight junctions. And then I'm going to put him on a new product, the humus extract called Restore, that has also been shown in bad toxic situations to restore tight junctions. So that's my plan for a very personal case that I'm kind of sick about. And I'll tell you, I guess the rest is to be continued, how he will do.
When treating SIBO with CFO and doing the antimicrobials, when do you start to get worried about the antimicrobials starting to affect negatively the microbiome?
So this is a great question because I would say if I just guess clinically, again, what I see, maybe 30 to 50% of my patients with SIBO also have SIFO, which is fungal overgrowth. And as you can imagine, Xifaxan, number one, rifaximin, has not been really shown to increase yeast. It also has been shown to act in the small bowel, and 95% of the colonic bacteria remain intact. So that drug is pretty safe for the microbiome. However, the adjuvants that are needed for methane SIBO, like neomycin or tinidazole or metronidazole, or anything else that you would use to treat microbial infections, will have a profound effect on the microbiome and will flare the yeast. So number one, if I have both, I will almost always use herbal regimens that treat both. Because if you pick something like oregano or caprylic acid or berberine, you're going to treat both and you won't flare either one. I have seen berberine by itself in very high doses, the doses needed to treat SIBO, which are about 5 grams a day, flare yeast. So just because it's an herb doesn't mean it won't flare yeast, it could. But usually if I combine, what I'll do is I'll do a combination. I love caprylic acid and oregano for antifungal. Oregano has both antibacterial, antifungal. Berberine is very good antibacterial, but may be a problem for fungal. And then you have like allicin extract and garlic. So I usually pick a combination program, and I'm usually going at least 8 weeks. SIBO you could eradicate in 8 weeks. With SIFO, you may need 3 to 6 months. So usually if I'm doing an antibacterial regimen, I'll keep them on the caprylic acid or the antifungal for a lot longer than that. And you can also add in compounded nystatin. It's non-absorbable, super safe. I use it in kids as young as 2 years old. Very effective, non-absorbable, super safe, and that's another way to do it as well.
Dr. Jill, right here. Does the Vibrant America, when you have bacterial overgrowth, does it also do bacterial sensitivity testing and make suggestions on herbs and drugs to use?
Susie? Sorry. No. Bottom line is they don't do sensitivity and specificity. It's just literally microbiome, like a snapshot of the microbiome. So in my mind, there's still uses for all of these. Nothing is completely replacing. Maybe it will in the future. But for them, they're going to do the snapshot of disease risk. And what I love about them is they've got 2,000 more bacteria. They're in the background waiting room. They're testing. They don't have the data yet to say this is clinically relevant. But I think as we progress, we're going to see more and more and more species. And I know they are on the cutting edge of what, just like the stuff I presented today, I haven't heard that from my other stool testing companies. It's pretty cool because I think the data, they're on the cutting edge of that. So hopefully we'll see that. But it doesn't do sensitivity, specificity, no parasites, no yeast. So.
Okay, thanks.
Can you just go a little bit further into the quinolinic acid and the IDO upregulation for the chiron pathway?
Yes.
And then you kind of segued into the FIGU for the B12. So I wasn't sure with that, with the MTHFR, SNP, and how do you feel that that process would work?
Okay, I wish I had my slide easily available for the IDO because a picture's worth 1,000 words. But here's the bottom line. IDO is an enzyme that is usually in the gut upregulated by a pathogenic trigger. So you'll see this in bipolar, schizophrenia, severe depression that's unresponsive to medications, children with autism or ADHD. So anything where the gut-brain is intricately connected and there's kind of this inflammatory, I think of it as an inflamed brain. And what happens is that IDO enzyme is triggered by yeast, bacteria, parasites, any sort of dysbiosis in the gut can trigger that. And what happens is tryptophan is a precursor of serotonin and next melatonin. So if we have tryptophan from, say, after your turkey dinner, everybody's happy and sleepy, that's because of the tryptophan. So tryptophan goes into serotonin and melatonin. And it's good for us, it's good for the body, all of that. We're happy, we're sleepy, we're all that. When the IDO enzyme is upregulated, that enzyme, what it does is it steals from the tryptophan stores, and instead of making your happy serotonin, it makes kynurenate. And kynurenate by itself isn't a bad guy, but when kynurenate becomes quinolinic acid, which you can test these things on organic acids in the urine, and when you see high quinolinic acid, that crosses into the brain and creates excitotoxicity. So the brain NMDA receptors are the calcium-related channels that are related to glutamate production and excessive excitotoxicity. And when you have quinolinic acid high, you have brain excitotoxicity, usually presenting in depression, anxiety, bipolar, mania, autism, ADHD, all of these brain disorders. So if you can go backwards and treat that trigger, which is usually an infection, you can bring down the quinolinic acid. Other things that bring down quinolinic acid are N-acetylcysteine, magnesium, and GABA. So you can use those as well.
I have a question again over here about SIBO, not to keep bringing this up, but correct me if I'm wrong, because I'm not 100% sure I have this right, but essentially the small intestine is not supposed to harbor any bacteria. So anything that's in there is obviously just on its way from our diet to the large intestine. And once it gets to the large intestine, these microorganisms find that to be a suitable environment by which they can thrive and multiply. So in a perfectly healthy situation, what is it about the small intestine that makes it not a hospitable environment for these microorganisms? Is it pH?
I think number one is pH, and well, what really happens is we're inoculated, of course, at birth, like you said, with and I'm sure our food, if we're getting some, stuff from the garden, or whatever, we're getting a little bit of that and we're taking probiotics. But that's a good question, because I'm not sure why they don't stick to the small bowel and stay there. I don't have an answer for that, but I think pH is part of it. It's going to be a little bit more alkaline as you get out of the duodenum, because that's the pancreatic enzyme requires alkalinization for it to work. And I know that your hydrochloric acid is one of your barriers up top, and if that's not working, you're going to have more overgrowth of the pathogens, because it's going to be more likely to survive. I don't know if that answers your question, but I don't know that I do have an answer for that.
Well, to me, the goal is to try to optimize the environment that makes it inhospitable, and that's not just to have an environment, right, of antimicrobials all the time.
Right. Well, and again, I think food would play into that, and because our foods that we eat, rosemary, if you're like me, here's another pearl. So I encourage patients, buy or grow fresh herbs of every type, rosemary, thyme, oregano, you name it, because those all have phenomenal antimicrobial properties. They have anti-inflammatory properties. They have anti-cancer properties. And if you're eating those daily versus just taking a pill of oregano, that's even better. Now, one thing I wanted to mention, not your question, but I think it's important. If you're having trouble with someone with SIBO that's recurrent, or SIBO in general, you have to think with the mind of a functional medicine doctor, which is why. Why did they get that? And other things that can cause SIBO, adhesions. So if they have had multiple surgeries and they have adhesions, or basically barriers mechanistically for the bowel to move. If they have autonomic dysfunction from an infection like Lyme disease, that can cause inability for the migrating motor complex to move, and then they're prone to, I think of it as a stagnant pond, right? Or I tell the patients when I'm describing the migrating motor complex, which is the flushing wave that goes through the small bowel, and that might be the key, the migrating motor complex. It's this flushing wave that flushes out the bacteria. If that's not working, you're going to get stagnation and overgrowth of bacteria. So that might be part of it as well.
We have 2 more questions for you. Thanks.
Right here in the front row. If you could find a good source of the donator, what do you think about fecal transplant?
So I think it's amazing. The data against, say, probiotics, it blows it away. The only indication right now in the U.S., since the FDA made it a procedure, even for me, I don't do it in clinical practice. You have to be certified or have some regulation to do it in clinical practice. But the only indication right now is C. diff colitis. So for those with IBS or inflammatory bowel disease, Crohn's or colitis, it's not indicated, so it'd be hard. They'd have to either do it themselves at home. And the big thing, like you said, fecal donor is huge. And I think I said at another presentation, unless it's someone, I wouldn't want a U.S. donor because most of the U.S. donor has glyphosate and garbage in their diet, even if they're trying to eat healthy. But I think there's profound benefit, and I think it's going to be a huge future thing if we can get it right and get the donors.
Just to follow up to that question on antibiotics, I try not to use antibiotics whenever I can, but when you have someone with a really difficult outpatient infection, wouldn't apply to Aaron, I guess, but somebody, say, had pneumonia, really bad, terrible sinusitis that you were sure was bacterial. Has anybody studied, is there a benefit to the gut in using parenteral antibiotics as opposed to oral antibiotics?
Yes. I think some of the Lyme literate docs do that because of the gut. So they're really bad gut patients, when they have to treat a really severe infection, will use IV. I think definitely. Yeah. Okay. Good.
Can I say thank you to Dr. Carnahan, please?
Thank you all for taking your Saturday. I'm honored just to be here with you. Thank you.
Everyone, I haven't had a chance to meet you all. My name is Eddie Bishop. I'm the National Sales Director for Vibrant America, and I truly want to say thank you. This has been the definition of community. Your attention, the quality of questions, and your time here. You spent a few bucks to get here. It's nominal, but it speaks volumes. I travel the country weekly